Hey everyone, today we're going to go over the 2017 Hypertension Guidelines released by the American College of Cardiology and the American Heart Association. No matter whether you're a nurse, physician assistant, nurse practitioner, or physician, these are the things you need to know. In this video of Hypertension Guidelines for 2017, it's two parts. There's one video we're watching now, which are the diagnostic criteria and guidelines for classifications and treatment recommendations. The second part of this video, which would follow, is the hypertension medications you need to choose, and all of those little sneaky caveats for each particular one, as well as all the high-yield things you need to know. Pay attention for that, or click the link to watch the second one. Let's get started. So first, let's jump into diagnostic criteria for hypertension. What is hypertension? Well, essentially just remember 120 systolic over 80 diastolic, right? Greater than. That's hypertension. But it's really important that it's not just one reading of hypertension. That's the big thing everybody always misses. It's an average of at least 3 office blood pressure readings. Well, how do you diagnose blood pressure hypertension outside of the office? Well, there's lots of different things you can use, and there's clear recommendations from the 2017 guidelines. First off, these average of 3 office blood pressure readings, that's not just one visit. They can't be all in one visit. That's over several weeks to months. Now, they can be a combination of home and office readings. But can you use just home readings? Absolutely. That's really important. You can have readings of a home blood pressure monitoring. So the patient has their own blood pressure cuff, or you get them to purchase one. Yes, I know, tough. Then they get their own blood pressure cuff, they know how to use it appropriately, and they measure their blood pressure every day. They should record the times, and the times are important because when they measure those times, you need to make sure it's an average of during the day. The average day blood pressures for a couple of weeks. If those averages range above 120 systolic or above 80 diastolic, we're going to go into the classifications of where they stand for hypertension. But you can use those measurements. Now, the third thing the 2017 recommendations say is that you can use an average of ambulatory continuous home blood pressure monitoring readings now. What is that? Well, with those, essentially, it's a blood pressure cuff that takes 24-hour measurements at home. And every 30 minutes or so, it takes a blood pressure reading. And it puts a little time stamp on there. If you take an average of those home readings from that continuous home blood pressure monitoring system and you average it out, you can get those readings as well to diagnose hypertension. And the big thing we see tested all the time is that 3 office visits. And it's not... Little Joe comes in the office, has high blood pressure. You say, ooh, let's wait 15 minutes and check it again. And then you check it again, it's high again. Well, let's wait 15 more minutes and check it again. And if all 3 of those are high, that doesn't count. It's really important that those readings need to be over several weeks to months in different office visits. But what about white coat hypertension? Specifically, the 2017 guidelines really want to make sure that we're making sure we're ruling out white coat hypertension because it's a real thing. But at the same time, little old granny or little old grandma or mama or whoever, they also sometimes just have hypertension and say, oh, I'm always this way when I come to the office. Well, guess what? This is where clear recommendations come in to say, why don't you get their blood pressure readings at home? Because those ones at home are the ones that you need to rely on. So you have them get the blood pressure readings, take them at home, and take those averages. And then, of course, those would use to classify whether they do have white coat hypertension or not. Now with this, next is diagnosing true diagnosis of hypertension. Where does JNC8 and those 2014 recommendations have differences between the new 2017 guidelines? And these are the things we're going to talk about in this video. So the 2014 guidelines made pretty clear demarcation between age 60 and different treatment guidelines for when to treat and when not to treat, and those readings of when to treat different patients based on age 60, as well as whether they have diabetes or CKD. What's CKD? Chronic kidney disease, of course. And then, of course, you'd want to treat them at above 140 or above 90 diastolic. Okay, well, that's old news. Let's talk about the 2017 guidelines. You've probably seen a lot of stuff about it. So what does it mean? Well, the things that the 2017 guidelines really focus in on are ASCVD risk. Well, what's ASCVD? Atherosclerotic cardiovascular disease risk. I know, say that 5 times fast. Atherosclerotic cardiovascular disease risk. Okay, I said it twice, that's enough. Well, what that risk is, what is it? It's a calculator. You can go online. There's so many different calculators that are available for free, and you can just type in all the information. What does the information want? Well, it wants their age. It wants their risk factors, like do they smoke? It wants their cholesterol readings, and of course, um, uh, what their blood pressure is. And it's going to give you a risk factor percentage based on age, smoking, and other factors. When you get that, the number, if it's greater than 10%, well, that's the key indicator when we're diagnosing and treating hypertension, greater than 10%. The other thing that 2017 guidelines look at are previous coronary artery disease. So, have they ever had a heart attack? Do they have known coronary artery disease, and that's significant, as well as then including from JNC8 the diabetes or chronic kidney disease. Now, most importantly is when you're going to treat at greater than 130 or over 80 diastolic. And the treatment, of course, then varies, and we'll go over those next. So you can see there's some clear differences. Over here, we're really focusing on age 60 and diabetes and CKD. 2017, they really want to focus on these risk factors. As we know, get more and more data, and we're able to crunch tons of numbers, we're able to get a lot of risk factors. You've probably seen ASCVD risk when you talk about hyperlipidemias and treating with statins and things like that with 7.5% risk, and that's absolutely correct. All of those things are coming, and we use this ASCVD risk very often, and you should know it. Now, when we talk about the stages of hypertension, what does that really mean? Well, before you probably remembered that there were just clear stages. It was really pretty simple just to remember pretty set numbers where it changed. And it's a little bit different. So this looks foreign to a lot of people if you learned the old JNC8 numbers. And let's look at them, and then we're going to animate through to kind of show you how they've changed and hopefully understand it. I've got two different ways to show you because, let me tell you what, I have trouble remembering this stuff. Like, you have no idea. It's so difficult. So JNC8. This is JNC8. You've probably seen it. Like I said, we've got normal blood pressure of less than 120 systolic over less than 80 diastolic. That's normal. Now, remember that any number, whether it's the top number or the bottom number, classifies you as the highest into the highest category. So if the diastolic number classifies into a different stage that's higher, that's the one that patient has. So when we talk about JNC8, remember that the numbers are 120, 121, 140, and 160. And we classify pre-hypertension, stage 1 hypertension, and stage 2 hypertension based on those 20 systolic and then range of 10 diastolic. So 120, 140, 160, 80, 90, and 100. Now, in the new 2017 guidelines, what they do is they get rid of this pre-hypertension stage and essentially shift everything on over. The stage 1 and stage 2 move on over. Let's take a look. In these 2017 guidelines, this is what it looks like now. A little different, right? Let's look through it. So essentially normal stays the same. Less than 120 systolic, less than 80 diastolic. That's the same. Good. One thing stays the same. That's nice. Now, what's different here is you can see that diastolic, well, less than 80 is still normal. But the systolic, less than 120, normal. But 121 to 129, over less than 80 diastolic is elevated blood pressure. Essentially what happened, they created this new category so that more people wouldn't be called pre-hypertension. They actually are called elevated blood pressure, and that requires intervention. And pretty much it's a good idea because pre-hypertension means I ain't got hypertension. I ain't got to worry about it, right? And that's essentially what they want to do. Along with that, now at 130 systolic, now that's classified as stage 1 hypertension. So greater than 130 systolic is stage 1 hypertension. And 81 to 89 diastolic is stage 1 hypertension. So it's a little different there. It's a little confusing. They've essentially labeled anyone with greater than 80 to 89 immediately classifies you as stage 1 hypertension. Because what's worse in high blood pressure? Systolic hypertension or diastolic hypertension? Diastolic, right? And that's what essentially is going on here. And as we move on to 140 systolic to over 90 diastolic, all the way above, it's stage 2 hypertension right away. Now, the hypertensive urgency, emergency, those are all still staying the same above 160. Those don't really change much because those are kind of separate guidelines as far as the treatment of regular everyday hypertension. So what you can do is easily remember that greater than 140/90 is stage 2 and start there and work backwards. So greater than 140/90, stage 2. Greater than 130/80, stage 1, and then remember that little nugget there of greater than 121 to 129 systolic, but less than 80 is elevated blood pressure, and then less than 120/80 is normal. That was confusing. Hard to follow, right? Let's look at it a different way in a graph to really illustrate the differences. So here's the old guidelines. I'm not going to go through them because when you say too many numbers, it just gets confusing. Well, plus I'm dyslexic, so I always get them backwards. But here's a graph that we're going to go through. So this is it illustrated. You can kind of save this for yourself so you have this image to kind of compare it to, especially the new one. Now here is where it's actually animated. Here's where we look at right now. Normal. We've got this pre-hypertension, which we called it in the old guidelines, stage 1 and stage 2. Now, essentially, everything shifts down. Everything shifts down because we're tightening down the guidelines to essentially classify more people with blood pressure elevations, right? That's exactly the problem. And then you saw all the media hype about how many more people are going to be classified with high blood pressure. Okay. Well, good, because a little bit of elevation in blood pressure usually leads to a little bit more elevation in blood pressure that probably needs to be treated. Now, let's actually animate through this to show the difference with the 2017 guidelines. Now, when you look at it, here's how it animates. You can see now what we've got here is 120/80, which is normal, less than, right? And then we've got now there's just a little bit of systolic here, 121 to 129, which is elevated blood pressure, but still less than 80 diastolic. Diastolic goes along the bottom, systolic goes along the left axis, right? Then, of course, 81 to 89 is stage 1 hypertension, or 131 to 139 systolic, and then essentially everything above 140 and everything above 90 is stage 2. You can see how we added so much more red here, which is essentially stage 2 hypertension. Now, what does that really mean? Well, of course, as we move on, that means there are new treatment recommendations along with each one of these guidelines. Here's a little chart showing you all the information you need to know. You can review this, take a look at it, save this for yourself so you can see those stages. You can see how it's illustrated here if the graph helps you. Or if you're somebody like me and you like to look at the little stages with the numbers side by side, you can use that one too. So, moving on. Who do we treat? Treatment recommendations, always important. We're going to talk about two things. What do we do for initial treatment, and then when do we reassess? Well, because that's really a part of the new guidelines is to make sure you have that reassessment piece in there. I feel like it's a lot of things as practitioners we forget to do. So first we talk about normal blood pressure. Well, if you're normal, you have a normal blood pressure now, all adults over age 18 need to have their blood pressure checked. That's great. You're doing great. Reinforce the great behavior, recommend some, whatever they're doing, keep it up, recommend some preventative things, recommend good diet, exercise, but then always reassess them every year. They need a reassessment annually. Every adult over 18 needs assessed every single year. Now, what about this new little nugget, the elevated blood pressure, folks? What do? Essentially what this means is these people are going to carry this diagnosis of elevated blood pressure, and these are the people that we need to then initiate treatment with what? Well, we're going to initiate with non-pharmacologic therapy. So essentially, diet, exercise, everything we're going to talk about in a minute and give some examples of those. And if you're diagnosed with elevated blood pressure, well, what we know, honestly, this doesn't work very often. That's why we need to reassess them in 3 to 6 months. We need to make sure that whatever we're doing is working and make sure that they're not progressing on to stage 1 hypertension, which unfortunately is what we see pretty common. So what about stage 1 hypertension? This is where it's really, really important. Remember that ASCVD risk? If they have stage 1 hypertension, regardless of age, what you need to do is assess the ASCVD risk, which takes into account the age and other risk factors, whether they have diabetes, whether they smoke, all of those things, and then calculate a risk. And if the risk factor, their 10-year risk of a cardiovascular event is less than 10%, that you're going to use non-pharmacologic therapy, just the same as the elevated blood pressure folks. So just like the old guidelines, that means these people don't get treatment. They don't need treatment because they're less than 140. Great. But what about the people who are over 10% cardiovascular risk in 10 years? Well, those people are now stage 1 treatment. They need pharmacologic treatment. They need non-pharmacologic therapy, the recommendations and the diet and exercise and all those things we're going to talk about in a sec, but they need pharmacotherapy. Now, for the specific pharmacotherapies, which one to choose, when to choose, why to choose, and all those caveats, you can check out the next video or click on the link and go ahead and skip to it yourself. So they're going to need both. And if you start in pharmacotherapy, they need reassessment in 1 month. They got to start both. You got to do both of them right then and there and start them on treatment and see them again in 1 month. About 4 weeks, right? 1 month. Now, what about stage 2 hypertension? Because this also, yes, you know you're going to do these things, but what's different for stage 2? The important thing here, and the clear recommendation from the 2017 guidelines, is that stage 2 hypertension, we know that blood pressure typically isn't usually controlled with one medication. And somebody with stage 2 hypertension typically needs starting on 2 medications. So you do the non-pharmacologic therapy, diet, exercise, all those lovely things. But you also start them on 1 or 2 medications because you know you're going to need to get there anyway, and then you need to reassess them as well in 1 month to make sure that they're meeting the goals. And what are the goals? Well, you want to get them below 130/80. That's the entire goal. You want to get them down. So let's run through that one more time really quick. A normal person, any adult age 18 and over, they need reassessed every year if they have normal blood pressure. That's really important. Those new elevated blood pressure folks, well, those are the ones now at risk, right? We've identified them as risk, and we know that they need to be giving non-pharmacologic therapy, and they've got to be reassessed then every 3 to 6 months or in 3 to 6 months. Our stage 1 people, we know the stage 1 people need to be assessed for their ASCVD risk, and if it's greater than 10%, that's a problem. If it's less than 10%, we're going to go ahead and shunt them back to the other group, and we're going to say non-pharmacologic therapy, reassess in 3 to 6 months. If they're greater than 10%, you're going to do non-pharmacologic therapy, diet, exercise, and pharmacotherapy with 1 drug. You're going to reassess them in 1 month. And our stage 2 hypertension, well, those are people you're going to start with the non-pharm stuff, diet, exercise, yes, and at the same time start them with drugs and 1 or 2 drugs. Perfectly okay starting with 2 at once because you know that you're going to end up getting there anyway. Now, what are those non-pharmacologic therapies? Now, I'm not going to go through these in great detail, but there's clear recommendations. Number 1 is diet. Low sodium diet. Higher potassium. Low potassium causes hypertension, associated with hypertension. But most importantly, along with both of those, is a DASH diet. What's a DASH diet? Well, DASH stands for Dietary Approaches to Stop Hypertension. That's smart. And that includes really a lot of sodium limitation, less than 2,300 milligrams per day, lots of grains, vegetables, fresh food. There's tons of books on it, tons of things you can do for a nice DASH diet. Now with these, there's lots of kind of estimations, we'll say, based on research, and I pulled some of these from different places, so don't send me any hate mail if a couple of these are off. They're just really rough estimates to kind of give you a clue. But essentially, a low sodium diet by itself, you're going to lower systolic a couple of millimeters of mercury. The DASH diet itself, pretty effective. You can lower it 10 systolic or 6 diastolic. About. These are all approximations based on what studies have shown, various ones. Lifestyle things, stop smoking. Just stop it. Limit the alcohol. Now, a little bit of alcohol, not a bad thing. Okay, good. But 1 to 2 drinks in men and 1 drink in ladies. Sorry, ladies, you only get 1 drink. But limiting alcohol can lower blood pressure, 5 systolic, about 5 points, systolic and diastolic. And of course, there's studies out there showing that those 1 to 2 drinks could be cardioprotective. I'll take it. Another big one, and the one I preach to my patients all the time, weight loss. Weight loss, weight loss, weight loss. Now, I put 20 kilos as 20 points, but essentially what it is 1 kilogram is about one point. I don't really know if 20 is always going to give you 20 points, but I always use that estimation for my patients, or I'll say 10 kilos, 10 points. It's a good realization that a lot of people, if they lost weight, they can control their blood pressure. Really great thing to do, because if there's more fat laying around, that's more pressure you need to pump through that fat. It's just gross, I know. But this is also why we see patients and we reassess them and they've gained weight and now their blood pressure is out of control and they need increases in their medication. Same with patients who then lose a lot of weight. Now they don't need blood pressure medicine. It's like magic. And of course, my favorite or least favorite is exercise. No, I'm kidding. I should exercise more. These are just to give you a good idea. Not going to go into great detail on these. There's lots of things and information on this. Well, thanks for watching today. You can watch both videos on the 2017 Hypertension Guidelines. The first video, well, it's about diagnosing hypertension and those new guideline changes. The second video is all about the medications, which one you use and when, and all those little disorders of why you choose which one. Be sure to check out some of my other videos for lots of other things you want. If you like the video, you can leave a nice comment, the nice comment where you write something nice. You can be about something else. Just write something nice to yourself if you want nice comments. Don't leave any of those troll comments. I don't like those. They're not nice. Thanks for watching, and as always, click the little subscribe button. Just go down there and click it. Just click it and love it. Just make it your little friend. Just click, 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 click. And as always, good luck studying.